Speaker is Stacey Clardy. Dr. Clardy, are you here? She's right there, sitting down, waving to me. Excellent. She is from just down south. Came up from on I-15 from the University of Utah. She's part of the clinical and research faculty at the department or the Division of Neuroimmunology in the Department of Neurology at the University of Utah School of Medicine. Her training, and then after her training, she did a fellowship in autoimmune neurology at the Mayo Clinic. And her experience, interest, and overall training really focuses on the evaluation and management of autoimmune and paraneoplastic neurologic disorders. And we're going to hear a little bit about some of that today. Her main interest is devoted to patients affected mostly by antibody-mediated disorders of the nervous system, as well as some of the demyelinating central nervous system diseases, including neuromyelitis optica and multiple sclerosis, as well as other CNS complications and other rheumatologic diseases. She has established the Autoimmune Neurology Clinic at the University of Utah, which is one of the very few clinics in the United States serving this particular group of patients. So we welcome Dr. Clardy.
Hi. Am I on? Thanks for having me. So I guess now I really don't have any excuse to just keep giving out Keppra. It's just so easy to prescribe. It's my favorite. Those are two great talks, actually, and were a perfect segue, actually. I didn't realize it. I wish I had sort of paid more attention to the chronology. The only thing that I would add from my biased perspective, some might say, is anytime that an adult presents with new onset of epilepsy without a clear etiology, that is familial, head trauma, stroke, the first question that I always ask myself is, why do you have epilepsy? If I cannot find something structurally wrong, if I cannot find a genetic reason, if there's nothing in your story that answers that question to me, and the reason I ask that is because of the entity of autoimmune epilepsy, with which I'm sure they're all familiar but didn't delve into because it's a lecture in and of itself. But this is increasingly recognized. This is not as rare as we thought it once was. And I think as time goes on, more and more of us will be picking these up in our practice. And in fact, I already have numerous patients, having just been at the university for less than a year, with autoimmune epilepsy. And this is important, of course, because the treatment is different. In some cases, many cases actually, we still use anti-epileptic medications. But these are folks that often come in on 3, 4, 5 medications. As soon as we identify the immunologic aspect or cause of their syndrome, we can often get that completely down with the anti-epileptics and replace it with immunotherapy, or at least work the two together and lower the anti-epileptics and have a greater success rate at controlling their epilepsy. So for my little piece of the world, I would say, incorporate that as well into the back of your mind when you see a new onset epilepsy in anyone and it just doesn't seem to fit. So let's see here. So no disclosures. So I wanted to talk to you really about two things. The first is autoimmune epilepsy, which you mentioned, and then the second will be multiple sclerosis, the two of which are not really mutually exclusive. And in fact, my MS clinic serves as fantastic fodder for my autoimmune clinic. And they often make quite a bit of fun of me over there, saying it's the un-MS clinic because I undiagnose more MS than I diagnose. But really, I think it serves to point out that this emerging field of autoimmune neurology is really much more common than we expect. And a lot of these folks that end up having just these white spots on the brain or unusual central nervous system presentations that seem MS-ish-like may actually have one of the other entities. So what is autoimmune neurology and what does it encompass? So it's really essentially the entire neuroaxis. I already talked just briefly about epilepsy, but dementias, especially your rapidly progressive dementias, any host of pain syndromes. Some of you might be familiar with voltage-gated potassium channel complex pain syndromes. This is a newer thing that was just described in the Green Journal a couple years ago. Again, a population of people high-dose opioids, highly resistant to pain therapies. When you looked at the patients as a whole, seemed to have an autoimmune flavor and in fact ended up having positive antibodies, could be treated completely off of the narcotics in some cases with just a little bit of an immunotherapy. So again, really changing the whole paradigm of how we think. Psychosis, agitation, encephalitis, that's more traditionally what we think of. Movement disorders. I'm shocked at how many individuals are walking into my clinic here in Utah with autoimmune or immune-mediated movement disorders. I've really had to brush up on my movement disorder skills because it's just so common for some reason in my referral basis here. Myelopathy, neuropathy, neuronopathy. Again, these are things we traditionally think of that way. Dysautonomia, especially involving the gut, right? As neurologists, we don't feel like dealing with the gut, but this so commonly intersects with our patient population because it has its own nervous system. And some of these patients, again, bounce around. The GI docs try everything they can for them. For gastroparesis patients, things like this, small subset of them, it is in fact antibody-mediated. And so the list kind of goes on and on. In fact, there was just a publication that came out within the past month, again, now looking at parasomnia as they've identified an antibody there. And again, these folks respond to immunotherapy. So this is sort of, if you're strict about it, antibody-mediated disorders, which I see. But the Autoimmune Neurology Clinic, we also see nervous system complications of celiac disease, CNS Sjogren's, CNS lupus, neurosarcoidosis. The list sort of marches on and on, sort of things for which we don't necessarily have the antibody, but certainly they're disimmune conditions affecting the neurologic symptom. Things like even Klippers syndrome, all kind of stuff. So you can see how the numbers are really enormous in terms of the volume of patients when you start looking at it as a whole. So I wanted to start with a case presentation, and please make this interactive. I'm not someone who minds being interrupted. Just kind of call out Stacey, and at any time here, if you want to call me on something I'm saying or take me to task on it, please feel free to. It's late in the day. I want people to be as involved as possible. So this is just a case I wanted to start out with, again, to kind of keep you a little involved. This is a 19-year-old woman I saw. This is a typical kind of patient for me. No past medical history. She had a 1-week illness. So mom tells me she had 2 days of vomiting and diarrhea, and that tingling you can kind of get in your fingertips. We usually think of sort of electrolyte imbalance kind of thing. And then after that, she just seemed a little cranky, but again, she's a 19-year-old female, mom said. But she called mom at work the one day and said, listen, there's a problem with the HVAC. And she said, I tried to check it out. She really must be quite a handy 19-year-old. Went down, was kind of looking at the air conditioning, at the furnace and stuff. She said, I cannot figure out where the buzzing is coming from, but there's a problem. You got to check it out when you get home, mom. Her brother was there and was like, I don't know what she's talking about. So they knew something was wrong when by day 5 of this week, she started slurring her speech a little bit, seemed to not be finding words, seemed a little confused, and again was complaining about this tingling in her hands. So family history, that brother we talked about, he does have epilepsy. And otherwise, we know that her father passed away in his 50s of colon cancer, so not too much there. She had just graduated high school. She was working at a local restaurant as a dishwasher. And she did note that she used some marijuana, but said she didn't drink or smoke tobacco. So on exam in the hospital when she arrived, expressive and receptive aphasia, really, but not sort of a pure one, just kind of complicated a bit by what seemed like a delirium or a lack of cooperativeness. But it does seem to fluctuate. So at times she would cooperate more than others with exam. But clearly no motor deficits on the exam at any time. So this was her MRI. Maybe I can convince you there's a little bit, maybe. It's a hard sell, right? T2 hyperintensity over there. And so they admitted her, 19-year-old with mental status changes, very appropriately did a CSF on day 1 and thought, oh my goodness, 124 nucleated cells. I think the team's first impression here was this is probably HSV encephalitis or, perhaps, she talked about the marijuana. Was she using spice? Was she using other drugs as well that we don't quite know the effects of? Or is this some sort of neuropsychiatric thing? Is she first presentation of schizophrenia? But this concerned them, but then they rechecked it on day 3 and it seemed to kind of be heading in the right direction. And again, day 16, you get the sense she was in the hospital for a couple weeks here, just kind of doing her thing. And she didn't have any oligoclonal bands. The hitch was they did patch, they checked the HSV PCR. It was negative twice from the CSF. And if you know anything about this test, it's pretty, as far as tests we have available goes, pretty sensitive and specific in the high 90s%. So they kind of continued treating with acyclovir. But weren't really sure. The EEG was not surprising, giving her exam, basically showed some diffuse slowing. So at this point, I actually heard the residents in the room talking about this patient and speculating on what other drugs she might be using. And so I actually asked them if I could swing by and see her quickly, and then suggested one additional test. Does anybody have any idea? An ANA? Oh, that's a great idea, yeah. No, actually, I didn't order that one. It's a fantastic idea. So 2 tests, actually, but I knew that one wouldn't be back for a while. And then one that I could get right away was a CT scan. So she had a mature ovarian teratoma, so who cares? Pretty common in OB-GYN. Anybody? What do we have now? Anybody say it? I know somebody knows it, you're just being shy. So this patient, in fact, has an NMDA receptor encephalitis. And this is a hard sell because this entity, of course, was only recently described by Joseph Dalmau when he was still at the University of Pennsylvania. He's now in Spain. But he noted a population of young women who retrospectively seem to have these teratomas, which we classically think of, especially mature dermoid cysts, as being benign, and we don't really touch them. And then put together that, in fact, this wasn't just a coincidence, and that probably nerve cell type tissue, neuronal tissue in those teratomas was somehow involved in maybe perhaps a molecular mimicry, and that's why these women had encephalitis. It was the initial thought. There's been a lot more work on it since then. So at any rate, I did the hard sell to OB-GYN here and did convince them to take it out, just that one ovary, because this is a 19-year-old woman. You want to preserve her, ability to have children. A very hard sell because they didn't believe in the entity. And then ultimately did 5 rounds of plasmapheresis, and after the first round, she had her first seizure, which didn't exactly make me look good, but then she continued to do quite well after that and was normal within a month, and being the 19-year-old that she was, refused additional immunotherapy, but did agree to follow extremely closely with me over the following year and did quite well. So let's talk about this a little bit. Probably, if most of us have heard of this, there's actually a book out now that was on the New York Times bestseller list by one of the young women, one of the earlier young women in the first couple hundred to be diagnosed with this entity. She happened to work for the New York Post, and so she wrote a book called Brain on Fire. It's a fantastic read. And I give this to every single family where I diagnose a family member with this condition. So it's mostly young women and children, not exclusively though. I do have some young men with this condition. Over half have an associated teratoma. If you have the teratoma, good news, because you take it out and then you fall into the lower risk of relapse group. Of course, if you're a child with this condition, most of them do not have the teratomas, and of course the men do not. It's a pretty characteristic progression, again, generalizations here. They tend to have a viral prodrome if you can get that, because there's a component of memory loss when you get them back, so they don't necessarily remember or haven't reported it. In the young females, not the children, but adolescents and up, they have the onset of psychiatric symptoms. I've had one patient present acute suicide attempt. Another patient, acute psychosis. And in fact, when they've done, yep, go ahead. NMDA? In terms of what it normally does, so excitatory neurotransmitter in the brain, an excitatory neurotransmitter in the brain. So we all have NMDA and NMDA receptors in our brain. N-methyl D-aspartate, I believe. I want to say the wrong. There is. Mm-hmm. So that was the second test that I sent off, but this was actually a case already from back in my last year residency, and at that time, in fact, ARUP here in Utah was one of the first to market in the US to make it commercially available, but I knew the lag time would be about 2 to 3 weeks, which that patient didn't have that kind of time. Mm-hmm. Absolutely. Yeah. Any?
The teratomas, are they usually confined to the ovaries, or could they be elsewhere? You get more cysts on the head?
Yeah, these tend to be ovarian. They've never really been observed in NMDA in association with other things. But of course, there's also this population, the men and the women who don't have it, right? So that raises the issue of what's going on there, and is it molecular mimicry from something else, and not an error the immune system made when attacking the cyst and then attacked the brain because perhaps they looked similar. So we're not really, again, It's not on 100%, it's not a definite kind of a thing. But yeah, we've never seen the association with other dermoid cysts. So yeah, so what I was saying, so they've done some epidemiology studies here, three really good ones. I don't have them in the presentation. And they looked at the onset of first-time psychotic episode. So all people who would present with first-time psychosis. And between the three studies, they came up with between 5 to 10% of all first-time psychosis, in fact, actually have this diagnosis. It was done retrospectively. And of them, many meet strict criteria for schizophrenia. So this is dramatic at times, you know, but and tricky, right? It has to be sitting in the back of your mind, or else we'll never miss it. And the heartbreaking thing, of course, is you think that there are certainly people undoubtedly sitting committed psychiatrically for life with this diagnosis, which is fully treatable. So generally, they can start psychiatric. Many, the fortunate ones, will go on to develop medical symptoms that get them off of that pathway and into another evaluation. So memory loss, seizures, decreased consciousness, abnormal movements. Actually, the video of like the baby that she showed at the end of her lecture, not quite like that, but many of them will develop an orofacial dyskinesia, funny movement like this. Some of them will posture dystonically. So those ones, then we get extra hints, right? And that makes it a little easier that we look for something else. But there are some that just stay strictly psychiatric for a little while. So excellent prognosis with treatment. That's the great news about this. But if it takes us longer to pick them out, which again, you can imagine it does, it takes a lot longer treatment. The second patient that I diagnosed, this one's sort of near and dear to my heart, it was the first one I picked up, and thank goodness we picked her up so early. She did remarkably well within a month. The second patient I came across was already trached and pegged and in an ICU for 3 months. It took me 2 years of hard-hitting immunotherapy to get her back. So long-term acute care hospital for 1.5 years of that, 2 years. And now she just has a little bit of slowness you can kind of detect when you talk to her. But otherwise, she was certainly pretty close to death. So again, variable, and it depends on how long it takes to diagnose, but treatable in most cases. So that's interesting, right? So you say that's a really cute case you have, and isn't that a cute academic case? But no, in fact, this is very common, okay? They've looked at the California Encephalitis Project. I don't know how many of you are familiar with that, but in California, they collect all cases of unknown encephalitis, and they send them to a central repository. And they looked at that retrospectively, and they found that NMDA encephalitis for their unknown cases in this population age range of sort of teens to early 40s, NMDA was more common than West Nile, VZV, HSV, sort of all of them put together. So again, this isn't just a cute thing, it's just something that we're beginning to recognize. It's been here all along, and we just didn't know about it. So here's the rate at which we're going in this field, and this is why I find it so exciting. Since 2007, these are the new just encephalitis-related antibodies that have been discovered. Voltage-gated potassium channel complex, LGI1, Caspr2. The LGI1s that our epileptologists are quite familiar with. This is associated with, these people always get called psychogenic because they do something like this, and done. Little faciobrachial dystonic seizures, very quick, 1 second long. They can go like that for a long time. Most of them eventually, over months, if this is not picked up on, will progress to an encephalitis. So just an example, and they keep going on and on and on. DPPX, one of the more recently described, this was first in 2013, came across a couple of cases of this when I was a fellow, and in fact, didn't have time to put in here today, but I think I just saw one yesterday. I'd put my nickel down on that it's going to come back in about a week as positive for DPPX. So this, again, is not rare. This gentleman was just referred in by a psychiatrist who said there's something a little bit weird about this gentleman's memory loss and acute depression. Can you please take a look at him? So again, pretty common. So what is this autoimmune neurologic disorder? Backing up a little bit. So I hinted at this a little bit, the theory. So the expression of neural proteins by a cancer, when these are associated with cancer, breaks immune tolerance to proteins normally expressed in the nervous system. So molecular mimicry, our immune system's making a mistake. It's doing a great job fighting off the cancer, and oops, now it thinks that a part of self actually is that cancer. We're not sure what happens in the people who never have a cancer. For some of them, did they in fact do a fantastic job of fighting off a cellular level malignancy, and so we never detected the malignancy, but they still have the memory B cells that are now attacking, possibly. For others of these, it seems like they just have a very clear sort of viral trigger or an acute emotional stress kind of a trigger. So we don't know the answers to all of them. The difference between whether we call it an autoimmune neurologic problem or a paraneoplastic neurologic problem is just whether or not we find the cancer. Otherwise, we're looking at the same sort of thing. So there's two kind of broad categories of antibodies and how they act in these. There's cell surface directed antibodies and intracellular antibodies. So the pathogenic antibodies, the ones where we know the antibody's doing the damage, tend to be against the cell surface ones. And almost all those encephalitides that I told you about are cell surface antigens. And so pretty much if you remove that antibody attack, the patients do well. So you pherese it off, you IVIG it, you give steroids, boom, they do very well. The trickier ones are the antibodies against the intracellular antigens. And here we think and theorize, because we don't know for sure yet, that this is mediated by a cytotoxic T cell response. So I promise this is the only figure like this in the whole presentation. I know that these can sometimes make the mind go numb. So just look at the red triangles and the green triangles. So the red triangles over here, whoa. There we go. So the red triangle there, that's going to be a cell surface antigen. And so the red antibodies bind directly, activate complement, and then the immune system is off and running. So the green triangles are down here, intracellular, and so they're acting via the MHC1 complex and a cytotoxic T cell process. So that's the theory behind the two main categories of how these autoimmune neurologic problems are acting. So you're saying to me, this is great, but everybody that walks in my office does not have this going on. So how do you, again, I'm going to keep arguing, these are very, very common. The more you look, the more you start seeing them. I've noticed this when I get one physician sending a referral, all of a sudden I get a whole lot more appropriate referrals from that physician in the next period of time. So often multifocal bizarre presentation. If I had $1 for every single time my patients get called psychogenic, right? Because they start with something odd, especially, you know, God help those NMDA patients, they tend to be young females, right? Who do we discriminate against? It's young females, you know, like that patient I showed you. Oh, she's using drugs. Oh, she's just, you know, a young female. So a lot of them get called that because it's a multifocal bizarre presentation. Subacute kind of onset. So, you know, this is, you know, let's take a dementia. These are not the person that had a slowly progressive dementia for the last 15 years. This is the person who tells you 2 years ago I was doing my job as an engineer, and now I don't know which way is left and right. That is the kind of presentation. Stuttering course, so sometimes they'll say, 6 months ago my left hand went numb, then I was fine, and now I have this new thing with my eyes. So that kind of a course. CSF abnormalities don't have to have them, and when they do have them, they can be subtle. So they don't, you know, have to have oligoclonal bands. Many of my patients, the only thing they have is a mildly elevated protein. And then for the more paraneoplastic kind of stuff, they'll often say, yeah, you know, especially for like traditional paraneoplastic antibodies like anti-Hu or Ana-1, these things that we've known about for years, they'll say, yeah, I was a 20-pack-year smoker kind of thing. And then some do have a very powerful family history of autoimmunity and some do not. But again, when you take sort of this whole picture, it at least kind of gives you the sense that maybe I'm heading in the right direction. This is a busy slide, and this is an incomplete list of the antibodies with which I deal in clinic. It's very incomplete at this point, getting more incomplete by the month. But the point here is to say that the presence of these antibodies should direct a malignancy search. But the presence of these antibodies does not define the phenotype. So when someone comes in and you get the sense that it is perhaps an autoimmune or paraneoplastic neurologic problem, we have very poor ability to predict which antibody is causing it. Because the point here is many of these antibodies can present in vastly different phenotypes. If I had more time, I'd go into that on sort of a more detailed basis. So here's some of the complexities, things to think about. You don't have to get CSF on all of these patients, and certainly, you can always refer to if you don't want to. It's helpful sometimes. It probably adds about 10% sensitivity. So if you send a serum for evaluation versus if you send a cerebrospinal fluid, you'll probably gain 10% sensitivity in the CSF. So that is to say, 10% of the time you won't pick it up in the serum. But you're going to usually cover most of your bases if you send for a good serum evaluation. But it is helpful, again, as I told you, because you can sort of get those subtle findings that, again, tell you to keep on plugging away. oh, maybe there's elevated protein, or oh, here's some oligoclonal bands, but this isn't an MS patient, this isn't that sort of thing. When you have, and this sort of we get at, when you have a woman with a suspected paraneoplastic disorder, you really should look for that malignancy, if something doesn't seem right here in an otherwise healthy person. Again, down here with the whole body PET scan. So this is very difficult, especially now that Medicare has changed their rules again. It's very difficult to get a PET scan. However, I've had reasonable success managing to get these done. There is another added 10% sensitivity. So if I have somebody that's antibody positive or has every other sign of having a paraneoplastic disorder, you can effectively, educate the insurance companies on this angle and say, listen, we're going to add another 10% sensitivity at finding this cancer and finding it early, and look how much money you're going to save. There's other, and PET serves other purposes as well. For one of my patients who I knew had an autoimmune or paraneoplastic issue just a month ago, I got a PET scan and in fact found aortitis from her inflammation. So, it is helpful in other ways, but you can't sell them so much on that. So also, again, I hinted on this. You can have paraneoplastic disorders without a detectable autoantibody. So there are a few in my clinic, not too many, who are what I refer to as unclassifieds, clearly have an autoimmune neurologic condition. They have the elevated CSF. Many of them have the findings on MRI of the brain. They have abnormal EEGs. They have the syndrome, but they're still unclassified. This is when it starts to get a bit tricky, but this should not be surprising, right? Because I showed you that slide that said we discovered 9 new antibodies in the past 7 years. So they might be undiagnosed right this minute, but as the years go on, they're getting closer and closer. And again, I've had no trouble getting these folks the resources that they need because they clearly meet all the criteria, when you really hammer down. Another pitfall that I've run into, and I think we've all run into in this field, is if they have a cancer, but then they have a different autoantibody. I showed you that busy slide. People have more than one cancer at a time occasionally, so you really do just need to continue with sort of persevering and making things line up. So I've found small cells, afterward when somebody otherwise had a different malignancy, but that wasn't causing their syndrome. So, what I always try to bring forward is that these are really not diagnostic zebras anymore. I remember when I was finishing up residency and I was meeting with the faculty and they said, congratulations, we heard you got a fellowship at the Mayo Clinic. I said, thanks, and they said, what exactly are you doing there? So it is traditionally thought of as niche, but this is really just recognition. So more and more, I think, and my clinic is sort of evidence of this. Again, when I came here to start it, I thought, it'll probably take a few years to build it up. And in fact, it hasn't. It just filled rapidly because there's increasing recognition of how common these things are. And it really, truly goes across every single subspecialty. So when you add up those numbers, they're not as rare as people once said that they were. And it is so important to catch them early. The sooner you can catch them, the better they do universally.
When you order the test for the antibodies, how many days are you shotgunning it, or do you choose a few that you order?
That's a great question. So this is evolving, and there are a few places in the country that offer the testing, correct? And it's variable. The results you get are variable. The quality control is variable. Some only offer individual antibodies. And in cases like NMDA, that's probably okay, because it seems to be a phenotype that we can usually pick out once you've seen one or two. But in the case of, the traditional lingo of anti-HU, anti-RE, anti-YO, also called ANA1, ANA2, and PCA1, we know that you can't, and that sometimes, in fact, people have multiple antibodies, because when the immune system misbehaves, it tends to do it in dramatic fashion. So to some extent, yeah, I tend to order an entire evaluation on a patient when the phenotype is clearly not dictating. And that has prevented me from making mistakes. And so while it seems, to me, I'm very cost conscious, and it is an upfront cost, but if that is all negative, and I know how the tests are done at the different labs, so I know that they offer you an evaluation and assortment, but some labs actually then sit down and look at the thing on immunofluorescence by a trained scientist to see if there's an unclassified there. Most other labs do not. So, again, it's looking at it that way. And so if it's completely negative, there's nothing suspicious, and I kind of tend to combine also at times, depending on the presentation, with an ANA, with some rheumatologic antibodies, then I can be confident in saying, no, this is not what's going on. So yeah, I do tend to get the full evaluation, full as it can be, given that there's new antibodies added all the time. And there's certain tricks of the trade. So after a while, you can divide things into encephalidity or not. You know, if it's a neuromuscular presentation, if it's a dementia presentation, that will help you narrow what you have to order as a first pass. But let's say somebody, you know, just kind of comes in with a rapidly progressive dementia and a clean MRI. Then yeah, I'm sending the full evaluation because you know, I know that there are numerous antibodies that can cause that. So, anything else? Go ahead.
Is there any reports of girls getting pregnant, something in this substrate onset condition in their school during pregnancy?
That's an excellent question. So I know of a couple cases in the literature, and then I know of one person. Oh, sorry. The question was, has anyone ever gotten pregnant while this is going on? And the answer is, and how do they do? And the answer is yes. There are sparse reports in the literature. And then I know of one case locally from one of my colleagues at the university. No, they do not spontaneously improve. They tend to relentlessly progress. And so in the cases in which I'm familiar, the physicians have often opted to treat with rituximab, which would not necessarily be first line initially, but it allows for, and rituximab in the first trimester, sort of toward the end of the first trimester, so then you get coverage for the entire rest of the pregnancy. And that, in the cases I'm thinking about, has been successful. Yeah, very, very dicey situation. Yeah. So, but no, they do not. There have been sort of, as people have gone back now, and I've had the opportunity to speak to a lot of physicians, you know, calling about patients. There have been some reports where it seems to be somewhat spontaneous remission or less so spontaneous remission, but with minimal treatment. So like, let's go back before this was described. Let's go back to like 2000. People have called me and they said, I had a patient with this, you know, and I'm convinced of it now. And they would have given them maybe just a short course of steroids and the patient did okay, but then came back to them 10 years later, you know, or relapsed or things like that. So it seems very variable, and it does seem that it can spontaneously remit in rare patients, but the stories of that I've heard that tends to come back. But again, that's sort of the smaller number. Any? So that's a great question. So we do some in-house in our lab. We do those on sort of our patient-by-patient basis and do what I was talking about. You take the serum and can put it on just an old-fashioned, you know, immunofluorescence assay, been around since the 50s, and that helps. I've been working a lot with ARUP because, you know, again, they're sort of chasing. All the labs who are trying to stay in this subspecialty are chasing constantly. And so I think ARUP is scaling up a little bit. Probably the most, you know, and again, I get no money from anyone, but the most comprehensive available is the Mayo. And they have the physicians reading all the slides and the fellow reading all the slides. So that's sort of an invaluable kind of aspect of it, is for someone to lay eyes on it who knows this is neurally specific, it does or does not meet the pattern for a given antibody, that sort of thing. Yeah.
So I'm still trying to figure out all these antibodies. You said you do immunofluorescence. When you're doing immunofluorescence, I'm assuming it's indirect immunofluorescence, not lab things or anything.
Right, indirect, yeah, serum.
And then the second thing is all these antibodies that you're doing, if they're negative or if they're positive, is your treatment different than if they're negative? And I can understand that can make you feel better about, okay, this is the diagnosis they've got. But does the positive antibody or lack of positivity change your ultimate treatment?
So when you get a positive antibody, the first question that comes across my mind is, okay, what's the titer? Because titer, if you look into the literature, and it has been published on most every individual antibody, titer is predictive often of chances of malignancy. So lower titer for some of them. Higher titer is more predictive of a malignancy, say. And then I do tailor treatment to the antibody. Again, is it a cell surface antibody or is it an intracellular? You know what I mean? So that's going to change your treatment. And then sort of duration, aggressiveness of treatment. So some of these, the paraneoplastic cerebellar degenerations, for example, they've been around for a while historically. We know about those. They are relentlessly progressive and difficult to treat. again, one where you have to catch them early. And the goal there, most often for me, is to just stop the relentless progression. If I get a little improvement, it's shocking and a great surprise, you know.
Are they titering it into immunofluorescence? How are they titering?
So not all of them are done by immunofluorescence. This gets into like a separate, the radioimmunoassay, you know, there's ELISAs, on and on. So, you know, you can kind of say, well, this all sounds a little bit, it's very personalized, right? Frankly, it's personalized medicine because the field is evolving so quickly, we don't have evidence-based trials. So what do I do to convince myself? I'm talking about giving immunotherapy. Most often, in the interest of doing no harm, I'm giving IV methylprednisolone. Well, you give that to a patient, I don't care what they have, they all feel better, right? So it's essential to do an objective measurement. So I will document objective abnormalities. In some patients, you know, if you have an autoimmune epilepsy, this is an EEG. I want an abnormal EEG. If it's a dementia, I want abnormal neuropsych testing. I'm going to get an MRI. I'm going to see if there's any abnormalities on there, some enhancement, some T2 flare, hyperintensity. You know, if it's one of the autonomic gastrointestinal attacks, you know, I'm going to get a GI transit study. I'm going to do all that. I want objective abnormality. We need to objectify this. Then I will give you a treatment trial. If we can objectify and if everything else fits into the puzzle. And that could be either IVIG or IV methylprednisolone commonly for a short duration of time, 6 to 8 weeks usually. And then you're going to come back immediately after the completion of that and we're going to test again. Because I don't want to just hear, yeah, I feel fantastic. Of course you do, you're on steroids. So we're going to re-objectify and I need to see a change. I need to see a change, one, to again convince ourselves, in this case, the antibodies, this immune process is mediating what's wrong with you. And then also to prove that the treatment is effective for you. Because what's the next step? If the treatment was effective and if we objectify improvement or change in your previously abnormal test, then we're going to be talking about steroid-sparing long-term immunotherapy, right? So before you sign somebody up for that, you have to be certain of what you're doing. So it really is a rapidly evolving field, which is why I love it. It's fantastic. I mean, it's just going at an incredible pace. I do get, it gives me pause because these are often misdiagnosed as degenerative, and many may go on to be that way if we miss them, and certainly we have. I do think of everything systemically. I think I'm sort of an internist at heart. I probably should have become an internist. And that's what I love because he's systemic. They have neurologic presentation to end up in my clinic, but when you dig down, they have systemic issues. Many of them, it is primary GI, gastroparesis kind of stuff. And then new treatment approaches are constantly emerging. I'm sure you're all aware of all the monoclonal antibodies coming out. The example of neuromyelitis optica, for instance, there's this eculizumab trial. It's rapidly kind of coming around. On the flip side, though, we don't have to go with these expensive things for many of these, which is encouraging. Good old steroids can work for some of these, at least short term. So again, earlier the better. So I'll do the diagnostic treatment trial early. And so that's that. Any other questions on that? Sure. Yeah, so for some of them, so NMDA, we have pretty high numbers now. So I think in Lancet Neurology in 2012, Dalmau published a retrospective on over 400 NMDA patients. About 50% will have an MRI abnormality. So again, that's why you kind of, once you get the feeling in your gut, this is really a persistence game, you can't say, negative MRI, move on. Same thing for many of these. And if they present with an encephalitis, those people present with encephalitis and only half have an MRI abnormality, right? But when the people come in with a neuronopathy or a neuropathy or things, perhaps even more challenging to get a hold of something, that's objective and really dig for it. Or some of these just have small fiber neuropathy, so their EMG is normal, so it can sort of be challenging and it's variable. So depending on the phenotype, the antibody, it all affects what percent will have an MRI abnormality.
Question regarding once you find the primary cancer and you treat it accordingly, does that help with the symptoms?
Yeah, did everybody hear that? Her question is, if you find a malignancy and then you treat it, does that help with the syndrome? And the answer is yes, many times, but not always. Certainly, you have to treat the cancer, right? That's step number one, and then that gives me the opportunity to work closely with the oncologist, which is always, great fun. But so that's always step number one. And same thing, when I was a fellow and calling physicians saying, you've got the paraneoplastic. Some of them are highly predictive of malignancy, like anti-Hu, Ana-1 in an adult, highly predictive. Even in children, tends to be predictive of neuroblastoma. But I say, did you find your malignancy? And if they have, then we talk about how's the patient doing? Are they through with their cancer-directed chemotherapy? How are they doing? And then we sort of, I'll often let them sort of resect if they can, do their chemo, and then evaluate the patient right after and say, okay, where are we at? In many, many cases of paraneoplastic syndromes, I'm impressed over and over again that the patient comes to me and says, the cancer was no problem. I could have cared less about the cancer. This syndrome is destroying my quality of life. And that's really the theme that I hear over and over. And so once the cancer is addressed, and then I'll talk with the oncologist to make sure they're okay with whatever immunotherapy I'm proposing, then we sort of go ahead with that to try to start. But in the case of, like, say, NMDA, again, cell surface, they do much better. You yank that cancer up, boom, they're already doing much better. So.
You mentioned steroids and IVIG and things like that. I'm just curious how rituximab would do with something like that.
Rituximab is used quite a bit and quite effectively in many of these, especially, so rituximab targets B cells. So very effective in many. Again, no randomized controlled trials. But yeah, it works for a good many. I tend to not throw it out there initially. I've noticed that there's two, sort of camps on that. Some people really love rituximab and they throw it right out on it. It gives me poise. It's in the system. It completely wipes out your B cells, for a good 5 to 6 months. I tend to not use it as first line in most anything. If I have a severe diabetic, sometimes I'm forced in that direction. Because my preference with some of the more common ones is to ease in with a little bit of steroid IVIG and then overlap that as I'm building up, say, a Cellcept or an Imuran. But let's say you have somebody that can't tolerate that for some reason. Sometimes your hand's forced with rituximab. I just had an NMO patient that way who had just really bad diabetes, and probably we could have managed short term with the steroids, but she had no interest. And so it sort of wiped those things out, and we went right to rituximab. I think she was just going to leave if I told her to take steroids, so it sort of forced the issue. But yeah, it does work quite well for some.
Your cancer evaluation, do you have a routine panel that you follow, or is it just more selective?
So for a cancer evaluation, you mean if somebody has a known malignancy and then they're coming?
No, or do you assess a paraneoplastic disorder, you're looking for cancer, do you kind of a routine?
I do. So that was that tricky table slide. So if I have the antibody and I don't have the cancer, this is something that we do have a lot of information on. The antibodies are very helpful in predicting what type of cancer and location. So once I have an antibody in hand, I definitely have a rank list. If I get an anti-Hu, Ana-1 back, boom, I'm going straight to the lung. If I don't find the small cell cancer in the lung, I'm going to look extrapulmonary. I'm going to go to the breast. I'm going to go elsewhere. So there's very much a pecking order once I get an antibody in hand. Same thing for anti-Yo, PCA1, breast, ovary, and then sort of go from there. So yeah, the antibodies very much help direct the malignancy search in most cases.
I'm just getting frustrated because I can't hear the question.
Oh, sorry.
And I'm anxious to go on with multiple sclerosis. So I'm wondering if we can do that and then the questions
Yeah,
after
absolutely.
the whole session. Thanks.
So for MS, I kind of just tried to pick something that would be relevant. So 2 things, we'll see if we get to it, and stop me when I, so here's MS, right? Here's what we have. This is, over on the left side there, we've got all our old treatments that have been around, well, not all old, but the treatments that have been around, injections. And then over here are 3 new oral therapies, right? So I thought I would talk about the oral therapies. I think everyone has, a nice comfort level with what's going on with the others. So fingolimod, teriflunomide, and dimethyl fumarate all came out within about 2 years of each other. And so almost too many choices almost at once. So fingolimod, I think this is fantastic. It was developed from a fungus used in Chinese medicine. I think this is a great reminder to sort of go back and look at those things. In a short summary, it's an S1P receptor modulator. So basically, it sequesters lymphocytes in the lymph nodes. And that's its mechanism of action. I'm always struck when we describe mechanism of action for MS drugs, since ultimately we don't know really what's going on with MS, but that's the mechanism for this one. And so a good number of side effects experienced with this medication and other diseases. The big contraindications are cardiac. And I put in the last year. Actually, I think on the label that's in the last 6 months if you've had any of those. I think I was a little biased. That tends to be my practice. Is if it's in the last year, I would really hesitate to give you fingolimod. So quite a list there. MI, angina, stroke, TIA. So, it really does knock out quite a few people right out the door, unfortunately. And then here's part 2 of the side effects. So macular edema, we have to keep our eyes on the eyes, so to speak. So ophthalmology checks, the usual liver checks that we do with pretty much any MS medication. And then with pretty much all of these, again, this isn't necessarily just fingolimod. It's always in my mind that we can activate these viral infections. Always with MS, because we tend to be treating the majority a young childbearing population. This is a pregnancy category C, and it takes 2 months to get out of the system. So a fair amount of monitoring. Again, I don't have any sort of pharmaceutical company relationship. So, just sort of talking honestly and from practice, it seems a lot of people to me are held up by the 6 hours of monitoring that it takes on the initial dose to sort of prescribe such a thing. Although my understanding is they've made it quite easy at this point, that they have somewhere you can send people and get it all done. And then requiring the frequent ophthalmologic evaluations are sort of some things that give people pause, especially patients. Patients want to get on with their life. They don't want to necessarily have to do other appointments as well. So that's what I hear from patients when I have them review this one. So teriflunomide, other option number 2, this one basically inhibits a mitochondrial enzyme in rapidly proliferating lymphocytes, and so by that mechanism decreases inflammation. That's the thought. There's other effects you see down at the bottom. Presumably they may as well be acting in MS. Again, we don't know. These are new medications. They sort of, as always seems to happen in MS, they prove that they work in the condition, and then they go backwards to try and figure out the details. So teriflunomide, some of the typical kind of side effects that I've actually heard from patients with pretty much all 3, the hair thinning. And again, this is easy to say, big deal, but we all have our vanity, and I've had many patients come off of medications just because of hair thinning, because it's significant, to them. But the nausea and vomiting will generally get everyone, that makes it difficult to go on about your day. And that one's also common to Tecfidera as well. So in this one, it was nice because the sister drug, leflunomide, has been used for many years in rheumatoid arthritis, so came in with a little bit more knowledge than with some of the other medications when it was applied to multiple sclerosis. The big concern here, of course, is pregnancy category X for patients, especially your young females with relapsing remitting. But in this case, also your young males, because they're cautioned not to father a child. So some of my patients, if they're in that younger category, straight away will sort of say, I'm going to hold on this one. If patients do become pregnant, as always happens, life happens, you can do sort of an activated charcoal-based washout, and that seems to have been okay in the trial, in that the fetuses did well. So third one, dimethyl fumarate, BG12, Tecfidera. This one is perhaps to me the most vague in that it activates the NRF2 pathway to defend against oxidative stress. So we're not even really talking so much about lymphocytes and things like that here. But they do sort of speculate that while that's the primary pathway they identified, perhaps more relevant is the shifting of the dendritic cells in inhibiting inflammation. Side effects here, the top 2 are huge. It seems to me so far in my experience that if you can get the folks through the first couple months, in many, the GI side effects will lessen, and to get them through, you give them the medication with a fatty food at the same time, and then for the flushing, you just have them take an aspirin beforehand, then it becomes manageable if they have it. So many of my patients who really, really don't want an injection will try to suffer through, and if they can for the first couple months, I don't know if that's anyone else's experience, they seem to do okay, it seems to lessen. Similar to sort of the interferons classically and the flu-like symptoms, they seem to just knock down a little bit after the first few months. This one I think has the patients, my practice approach is to educate the patients on every single option. for medications, send them home as well, have them contact me with questions. What I've seen is a lot of patients seem to be going for Tecfidera when they do their own homework. And my approach is very much you're in control. Here's all the information. You decide. A lot seem to go for it, I guess, based on the side effects and sort of the monitoring required. So in the last couple of seconds, let's talk real briefly about vitamin D. This always strikes me. I always view medicine at times as being such a trendy thing. And when vitamin D first came along, I thought, oh boy, here we go, it's just trendy again. But I've since sort of turned around on that. The sheer volume of data on vitamin D, not just in multiple sclerosis, but really in sort of many conditions, autoimmune and otherwise, is growing, and it's really hard to ignore at this point. Here's a list of sort of circumstantial things that we've known about for a long time that make sense. And the last one's probably even more compelling to me, sort of on the research side, is the presence of the vitamin D response elements in HLA-DRB1, which is, of course, strongly associated with MS. Let me skip through that one. So this was probably, in one of my opinions, there was a study by Simpson in 2010, and it seemed to me to have sparked several others immediately after on vitamin D. They took a prospective observational cohort, 145 relapsing remitting MS patients, and followed for a little over 2 years, not surprisingly, 75% women, and most on immunotherapy. 52% of them were on vitamin D supplements, and of that 52%, 30% were taking greater than 400 IU a day, which is not very high. In fact, 400 IU is what pediatricians now recommend for babies and children routinely. And then they checked a vitamin D serum level every 6 months, and pretty compelling, basically broken down, the higher your vitamin D level, the more reduced hazard of a relapse. And since then, many people have done that. One of the more recent ones that I thought was interesting because of the number of patients, someone looked retrospectively at the BENEFIT trial. This is a big trial in MS. And they found of the over 400 some patients that 334 of them had actually had vitamin D levels checked at 6 and 12 months. So they looked at that retrospectively. And here they got a little bit more honed in on quantifying how much vitamin D in MS. And those who had values greater than or equal to 50 nanomole per liter. And this is important here because all of our labs measure this differently. So 50 nanomole per liter is equal to 20 nanogram per ml. At 12 months, predicted lower disability during the subsequent 4 years. So it's pretty dramatic data, in my opinion. Recommended intake, according to the Institute of Medicine report from 2010, 800 IU a day, just period, across the board. We're not talking about MS here. They said the safe maximum intake is about 4,000 international units a day. And of course, everybody, not everybody, people tend to think, well, if some's good, more is better. So I always have people coming in toxic. So I am very careful to caution that there's a sweet spot to my MS patients. I actually rarely have to give more than 4,000 IU a day to get them in range, actually. It's the rare case that they need 5,000 a day for a period of time. It seems to work better if we use D3 in terms of absorption. That makes sense on a biochemical level. And again, once I start them on it, I tend to check. I'm usually bringing them back in 3 months anyway if they're a new diagnosis or new patient to me, and then I'll recheck at that time to see where they're heading. So hopefully I wrapped up there. I just wanted to thank all those people. Thanks so much for having me. And of course, my work and research and everything is highly dependent on the patients, and so I'm always gratefully indebted to them. Any more questions?
Go back one slide.
Sorry, I had to kind of fly through that a little bit. I just wanted to give you a flavor of sort of both the worlds. No, nothing. Thank you.